A presentation on malaria diagnosis by wawira. The introduction. Malaria must be recognized promptly in order to treat the patient in time and to further prevent spread of infection in the community by local mosquitoes. Malaria should be considered a potential medical emergency and should be treated accordingly. Delay in diagnosis and treatment leads to death. It can be suspected based on the patient's travel history, symptoms, and the physical findings at examination. However, for a definitive diagnosis to be made, laboratory tests must demonstrate the malaria parasite or their components. Difficulties in diagnosis. Where diagnosis of malaria can be difficult. Where malaria is not endemic anymore, healthcare providers may not be familiar with the disease. Clinicians seeing a malaria patient may forget to consider malaria among these potential diagnoses and not order the needed diagnostic tests. Laboratorians may lack experience with malaria and fail to detect these parasites when examining blood smears under the microscope. In some malaria endemic areas, malaria transmission is so intense that a large proportion of the population is infected but not made ill by the parasites. Such carriers have developed just enough immunity to protect them from malarial illness, but not from malaria infection. In that situation, in, in that situation, finding malaria parasites in an ill person does not necessarily mean that the illness is caused by the parasites. Clinical diagnosis. The first symptoms of malaria most often are fever, chills, sweats, headaches, muscle pains, nausea, and vomiting. These are often not specific and are also found in other diseases such as the flu and common viral infection. The physical findings are also not specific, that is, elevated temperature, perspiration, tiredness. In severe malaria, primarily caused by Plasmodium falciparum, clinical findings like confusion, coma, neurologic focal signs, severe anemia, respiratory difficulties are most striking and may increase the index of suspicion for malaria. In addition to ordering the malaria-specific diagnostic tests described, the healthcare provider should conduct an initial workup and request a complete blood count and a routine chemistry panel. In the event that the person does have a positive malaria test, these additional tests will be useful in determining whether the patient has uncomplicated or severe manifestations of the malaria infection. Specifically, these tests can detect severe anemia, hypoglycemia, renal failure, hyperbilirubinemia, and acid-base disturbances. Microscopic diagnosis. Microscopic diagnosis can be identified by examining under the microscope a drop of the patient's blood, spread out as a blood smear on a microscopic slide. Prior to examination, the specimen is stained, most often with a Jameson stain to give the parasites a distinctive appearance. This technique remains the gold standard for laboratory confirmation of malaria. However, it depends on the quality of the reagents, of the microscope, and on the experience of the laboratorian. Antigen detection. Various kits are available to detect antigens derived from malaria parasites. Such immunologic or immunochromatographic tests most often use a dipstick or cassette format and provide results in 2 to 15 minutes. These rapid diagnostic tests, RTDs, offer a useful alternative to microscopy in situations where reliable microscopic diagnosis is not available. Malaria LTDs are currently used in some clinical settings and programs. The World Health Organization is conducting comparative performance evaluation of many of the LTDs, which are commercially available worldwide based on a panel of parasites derived from a global network of collection sites. The sites of these testings are available at the link indicated. Molecular diagnosis. Parasitic nucleic acids are detected using polymerase chain reaction, PCR. Although this technique may be slightly more sensitive than smear microscopy, it is of limited utility for the diagnosis of acutely ill patients in the standard healthcare setting. PCR results are often not available quickly enough to be of value in establishing the diagnosis of malaria infection. PCR is most useful for confirming the species of malarial parasite after the diagnosis has been established by either smear microscopy or LTD. Serology. Serology detects antibodies against malaria parasites using either indirect immunofluorescence (IFA) or enzyme-linked immunosorbent assay (ELISA). Serology does not detect current infection, but rather measures past exposure. Drug resistance tests. Drug resistance tests must be performed in specialized laboratory to assess the susceptibility to antimalarial compounds of parasites collected from a specific patient. Two main laboratory methods are available. One, in vitro tests. The parasites are grown in culture in the presence of increasing concentrations of drugs. The drug concentration that inhibits parasite growth is used as endpoint. Two, molecular characterization. Molecular markers assessed by PCR or gene sequencing also allow the prediction to some degree of resistance to some drugs. The CDC recommends that all cases of malaria diagnosed should be evaluated for evidence of drug resistance. The end.